From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Hello, and welcome to the JAMA Cardiology podcast. I'm your host, Dr. Kristen Patton. I'm a professor of medicine at the University of Washington and an associate editor for JAMA Cardiology. Today's guests are Dr. Søren Diederichsen from the Department of Cardiology at Copenhagen University Hospital, who led the study we'll be discussing today, and Dr. Mark Schoenfeld, who is a professor of medicine at Yale University, a past president of the Heart Rhythm Society, and was vice chair of the ACC-AHA guidelines on bradycardia and conduction delay. We're going to be discussing an analysis on the prevalence and, importantly, the prognostic significance of bradyarrhythmias in patients enrolled in a screening trial for atrial fibrillation. This is a post-hoc analysis of the LOOP study, which assessed the benefit of implanted loop recorder screening in patients at risk of atrial fibrillation and stroke. Søren, why don't you start us off with a little bit of background on the LOOP study and what motivated you to study bradyarrhythmias in this dataset?
Sure. Thank you so much for having me. I've really been looking forward to discuss this data. I'm very happy that we are publishing this with JAMA Cardiology and discussing it on the podcast. The LOOP study is a screening trial, a randomized controlled trial that we conducted in 4 centers in Denmark. 6,000 persons were aged at least 70 years and had stroke risk factors, but did not have atrial fibrillation or other arrhythmias. And these people were identified by registries to have these risk factors and then invited via letter invitation to their homes. So they were not patients, they were people invited from their homes to participate in a screening trial. And this trial then, we randomized these eligible people to either receiving a screening for atrial fibrillation using an implantable loop recorder or usual care, no screening. And this was a trial that was reported 1.5 years ago at the ESC 2021. And of course, the background for this trial was to really see if we can prevent stroke using a rather intensive way of screening for atrial fibrillation. And the outcome of stroke was then assessed, and that was a neutral trial. But I also think it's fair to say there was a signal towards stroke prevention. And also, we saw a lot of atrial fibrillation in the ILR group. About 1 in 3 participants in that group had atrial fibrillation diagnosed. And then, after having conducted this trial, we started to wonder what else can we learn from this work that we did. And I sensed, and I think that a lot of clinicians sense, that there's increased heart rhythm monitoring going on in the world, both in and outside the traditional clinical setting. There's really a lot of heart rhythm monitoring going on, and this maybe especially pertains to wearables and atrial fibrillation screening. So we started to wonder really, what about the underlying prevalence of other arrhythmias than atrial fibrillation? Other arrhythmias that could potentially be detected more and more when we start looking for atrial fibrillation in people with relevant risk factors. And so really, what's the underlying prevalence of such bradyarrhythmias maybe, and what is the prognostic significance of those? And what about, is there a link between atrial fibrillation and bradyarrhythmias? And what can we learn from having conducted a randomized trial where one group was screened rather intensively and one group received totally usual care? So that's a little bit of the background for what we did and what we have reported in this issue of JAMA Cardiology.
That's fantastic. I really commend you for thinking about looking at bradyarrhythmias. I know, Mark, when you led the bradycardia guidelines, did you see any issues with respect to data that we have that are relatively recent for these disorders? Were you happy to see these new data coming along?
Well, absolutely, because traditionally the guidelines, as most recently established, have emphasized not just a number, that is not bradycardia per se, but symptomatic bradycardia. And that has been the guiding light, if you will, for treatment with typically anti-bradycardia therapy with pacing. Here, it is not always the case in this study that bradycardia that was detected was symptomatic. In fact, in the majority of patients, it was asymptomatic. Upwards of 80% of the patients were without symptoms. So what it attests to is the fact that there is a high incidence of bradyarrhythmias that are detectable by implantable loop recording techniques that would otherwise be unsuspected. And in so looking for these, have we opened up, if you will, a Pandora's box, that we have now patients that may or may not warrant further investigation and or therapy. These are not typically the patients that would have met the guidelines for anti-bradycardia pacing according to the 2018 guidelines.
Søren, I'd like to turn back to you to hear for our listeners what you think of as really the major finding of the trial.
Yeah, sure. I think the main findings of this sub-study is, first, we can say pretty precisely how many people have clinical or subclinical bradyarrhythmias. Because I would say an implantable loop recorder is a pretty sensitive way for detecting bradyarrhythmias. And then, secondly, how do these associate with clinical outcomes? And how does the treatment of these and detection and treatment of these associate with clinical outcomes? So for the first of these major findings, we had this sample of 6,000 persons included in the trial, and close to 500 of these had a adjudicated bradyarrhythmia diagnosed during follow-up. And that was almost 21% in the screening arm compared to just about 4% in the usual care arm. So that was a highly significant difference with a hazard ratio of 6.2. Especially during the first year after loop recorder implantation, we really saw a lot of bradyarrhythmias. So I would say that's the first major finding, that more than 20% of these persons older than 70 years and with stroke risk factors, but without any known arrhythmias, they had bradyarrhythmias adjudicated. And all subtypes of bradyarrhythmias were more commonly seen in the screening arm compared to usual care. Also, we saw, as I already mentioned, a lot of atrial fibrillation during follow-up, and bradyarrhythmias were even more common in persons with atrial fibrillation than without, and we were able to really see how are these two types of arrhythmias associated and which of these come first, typically. The most common type of bradyarrhythmia was sinus node disease, which was seen in about 14% of persons in the screening arm, but also high-grade AV blocks was not rare. It was seen in about 3% of all. And then just to round up the sort of the prevalence part of the main findings, I think I'd like to mention a little bit about symptoms, as Dr. Schoenfeld also discussed a little bit, because symptoms were completely absent in a very significant proportion of all of the people with bradyarrhythmias. And maybe, of course, so it was even more asymptomatic in the ILR diagnosed bradyarrhythmias than the usual care diagnosed bradyarrhythmias. For instance, 18% of all with high-grade AV blocks had no symptoms whatsoever. So I think that was the first part of the major findings, that bradyarrhythmia is really, really commonly seen. Even high-grade AV blocks were rather commonly seen, and symptoms were very scarce.
These are such great data. I'm really happy you did this analysis. Can you tell us a little bit more about how you diagnosed bradyarrhythmias in both the ILR group and the control group?
Yeah, in the ILR group, we used a standardized programming for the device to sort of capture a lot of bradyarrhythmias. We had a cutoff of 3 seconds for asystole, bradycardia below 30 beats per minute over 8 beats to really be able to see all episodes. But we then adjudicated all bradyarrhythmias to make sure that we discarded physiological findings, very short asystolia during sleep, and first-degree AV blocks during sleep, and low-grade AV blocks. So the bradyarrhythmias that we reported are, at least to some degree, associated with pathology, is our belief. But then again, this is a study where we use a loop recorder in people who don't have a bradycardia indication for even having the loop recorder. It's a screening study. So it's we are seeing a lot, and we're trying to really focus on, okay, what are these clinical disease or what are they? But at least they are in the field where you could say in the clinic that this is something that maybe required a clinical attention. And in the usual care group, we didn't do anything. And in both groups, there wasn't a protocolized way of managing the bradyarrhythmias. This was really left to the discretion of the attending physician in the whole study. So everybody received sort of usual care for whatever bradyarrhythmia they had to diagnose. The only difference was if they received a loop recorder or not.
Got it. And I'm really happy to hear that you reviewed all of the ILR tracings, because certainly we know that not everything that the ILR categorizes as an arrhythmia is actually an arrhythmia when you look at it. I'm curious how you decided if arrhythmias were associated with sleep. Was it just the hours, or did you confirm with the population?
Yeah, I can tell you that if it occurred in the middle of night, we anticipate this was during sleep. But if it didn't, then we phoned every participant to make sure that were they asleep, because we anyway had to find out if they had symptoms. So we recorded symptoms based on if they told us they had symptoms when we approached them. And now we're talking about participants in the ILR group. So these participants were directly asked about symptoms unless they had a syncope and were admitted to the hospital before we actually captured the data, then we knew they had symptoms. But we asked them about symptoms, and even when we asked them, they had this rather low prevalence of symptoms. I would have expected that they had reported more symptoms when we so frankly just asked them about it. But we really saw a lot of arrhythmias with even significant, or from a clinical point of view, from an electrophysiology point of view, significant bradyarrhythmias, but very rarely associated with symptoms in the ILR group.
It's really surprising how asymptomatic a lot of these patients were. And Mark, you also focused a lot on symptoms. Can you tell us a little bit about the context clinically of why that's so important in bradyarrhythmias?
Generally speaking, when you think about it, the treatment of medical conditions or surgical conditions, the two primary issues that we contend with are alleviation of symptoms and survival. So what we spend a good portion of what we do has to do with symptomatic relief. And if the patient is asymptomatic to begin with, then we can't make the patient feel any better by implanting, for example, a pacemaker. In fact, we can sometimes create more issues, whether it be a risk of a invasive procedure, whether it be creation of a pacemaker syndrome, and the like. So then the separate issue has to do with mortality. And generally speaking, sick sinus syndrome as an entity, so-called tachycardia bradycardia syndrome, would not be typically associated with a far greater mortality. I think that is really assigned to the condition of complete heart block, which in Dr. Diederichsen's study was nonetheless identified in a smaller percentage of patients. I don't think it's totally surprising that we saw a significant incidence of bradycardia in these patients. And again, I think it is very important that how this was ascertained is extremely important, because it is well recognized with implantable loop recorders that there are many false positive detections of bradycardia or asystole. Very commonly, we see, for example, PVCs that may be registered as bradycardia in the way the algorithms are set up. And of course, the subcutaneous deployment of these devices makes them very prone towards spurious transmissions and alerts, very notably for atrial fibrillation. So it is very good to note that these have been adjudicated, that the timing has been ascertained. But according to, for example, the 2018 guidelines, we do not routinely recommend therapy or further investigation for patients who have nocturnal bradycardia, which will typically, by definition, be asymptomatic and can be very, very commonly seen, and not surprisingly so in the context of, for example, increased vagal tone.
I also really want to emphasize that these were all adjudicated bradyarrhythmias. All of the ECG material from the ILRs was analyzed by experienced physicians. So we know that there could be problem with undersensing, with misinterpretation of ventricular extra beats, and so forth. So the bradycardias that we report, I think, are a rather valid statement of the underlying prevalence of, to some extent, pathologic, bradyarrhythmia in this type of population. Then the question is this a disease, a clinical disease that even needs detection and treatment, or is it a risk marker that maybe needs some sort of attention, or is it really something that just is part of normal physiology, maybe aging, that doesn't need any sort of clinical attention or workup at all?
I absolutely agree. And I think your study really shows some provocative findings with respect to the prognosis of a diagnosis of bradycardia. Can you tell us a little bit more about what happened to these patients with their diagnoses and how that impacted their outcomes?
Sure. And as I told you, for the downstream treatment and the further workup that happens in the case of bradyarrhythmia, we as researchers only just went through all of the medical records to see what happened. We didn't have a trial protocol for how to treat and further work up the patients that had bradyarrhythmias. But the majority of ILR-detected bradyarrhythmias were treated conservatively, whereas usual care detected bradyarrhythmia was most often treated with pacemaker implantation. But still, in the whole population of 6,000 participants, 199 persons received a pacemaker implant. And in the whole population, the risk of ending up with a pacemaker was significantly higher in the screening arm compared to usual care. In the screening arm, 4.5% received a pacemaker compared to 2.9% in the usual care arm. So that was also a significant difference with a hazard ratio of 1.5. So about 50% higher risk of actually ending up with a pacemaker because you were in the screening arm screened for atrial fibrillation without us having required that you actually treat what you see in terms of bradyarrhythmias.
I think that when you have a technology such as implantable loop recorders that increase the yield and the sensitivity, I don't think it's surprising at all that we see bradyarrhythmias identified. I think what I was surprised about was the magnitude in the implantable loop recorder. According to your study, close to 21% compared to 3.8% of the control group, namely a six-fold increase. I mean, that is astounding. So it almost would seem to guarantee in that group a higher incidence of pacemaker implantation. So I guess going back to the guidelines approach, how do you account for a higher pacemaker implantation in the implantable loop group? Was it because bradycardia was identified and therefore felt a necessity to be treated, or were these patients truly symptomatic, or how did they meld with the current guidelines?
Yeah, that's a good question, and maybe so the most relevant question for this whole research, because this study was conducted until 2.5 years ago. So we, of course, have guidelines for a patient with symptoms who comes in and there's a suspected bradyarrhythmia, and you do something, you confirm the diagnosis, and then you implant a pacemaker. But these were patients that were screened for something else as part of a clinical study. So I think they are just a picture of what can happen when we maybe start screening for atrial fibrillation. We see a lot of incidental diagnoses of bradyarrhythmias. Again, as you said, more than 20% have clinical bradyarrhythmias, and we don't really know what to do with those. We asked them for symptoms. Few of them had symptoms. Actually, the added diagnoses, these six-fold increase, that was really only asymptomatic cases that was added, which is no surprise because those who had symptoms, we have pretty good healthcare, I hope. So those with symptoms without a screening will come to the healthcare system, will have the diagnosis of bradyarrhythmia. What we added with the screening was only asymptomatic cases, and still the pacemaker implantations increased quite a bit. And I believe that some of these pacemakers may have been implanted because the clinicians sort of felt obliged to when seeing a bradyarrhythmia that looked pretty clinical, high-grade AV block, for instance, even though it was maybe something that hadn't been going on for very long. It maybe came and went. It was a few episodes, but a clear, complete heart block going on for some time. And the clinician felt advised to implant a pacemaker without waiting for this to sort of deteriorate into a more clinical situation. So we see a lot more pacemaker implants, and I think to some degree, this has to do with the clinician feeling obliged to do it, even though there's no symptoms at all, which is conflicting somewhat with the guidelines. And the reason this is interesting is also that we could expect this to happen more and more in the future with persons with some risk factors and some underlying prevalence of bradyarrhythmias, screening themselves or monitoring their own heart rhythm with various tools that they get access to outside the clinical setting. And we haven't even talked about what happened afterwards for the clinical outcomes.
Exactly. And I think that's what's so fascinating about your study is that the results really give us pause about what we can assume with respect to these incidentally diagnosed bradyarrhythmias. So what happened to these people who got pacemakers, and were there any differences between the groups?
Yeah, first off, we also adjudicated all data for syncope and for death and subtypes of death, cardiovascular death and sudden cardiovascular death, and then looked and compared the two groups. So syncope having about 150 participants, 2.2% in the screening arm, 2.7% in the usual care arm, so a little bit more syncope in sort of a frequentist in numerical terms, but nowhere near a significant difference between the groups when looking at the hazard of syncope. So even though we implanted more pacemakers in the screening arm, we didn't see a signal towards protecting participants from syncope.
So more pacemakers for bradycardia, no difference in syncope, no difference in sudden death, no difference in cardiovascular death. That's remarkable.
Yeah, that's true. So I think it's fair to mention that this study is a post-hoc analysis. It's not powered to look at these outcomes. Of course, when you take a healthy population, invite them from their homes, these are, of course, they have risk factors for stroke, but they are healthy. They're not recruited from the hospital. They don't have arrhythmias. Then you won't see that many outcomes. You won't see a very small effect, for instance, on syncope. But we do have a number of syncopes, a number of sudden cardiovascular deaths, a number of cardiovascular deaths, and we don't really see a signal at all towards protection from being screened and monitored and treated for bradyarrhythmias in this way.
Wow. I think this has a lot of implications for how we think about patients, as you've said, with the increase in wearables, as well as patients that we're monitoring, for example, inpatients that we get consults on the cardiology service. Mark, do these results change at all how you think about how you're going to manage these populations?
Given the limits of its facility to attend to all of these patients, because we see this all the time, it does not change the emphasis on symptomatic bradycardia with regard to treatment modalities in that regard. But I do think that it identifies, number one, a revisiting, as in this study, as to why patients with bradycardia identified in this modality were treated and whether they should be treated, recognizing that there are risks entailed in that, particularly if it doesn't have any impact. I think that the outcomes with regard to syncope may be partly explicable in the sense that syncope can, has been well recognized, be multifactorial. If you look hard enough, you can identify more than one basis for syncope, and it may not have been bradycardia responsible for syncope in longer-term follow-up of these patients. And I think the same applies to sudden death. And I think that what we see here, however, that Dr. Diederichsen has identified is the potential concept that bradycardia, whether symptomatic or asymptomatic, may be a risk factor for something more sinister that has not been previously identified, of some other perhaps non-arrhythmic condition that cannot be treated with anti-bradycardia pacing. And the presence or absence of bradycardia and the amelioration of bradycardia may be misdirecting our efforts. It is, for example, almost analogous to what we do with atrial fibrillation, where the misconception all along has been that if a patient with past atrial fibrillation comes in with a stroke, it clearly was related to an episodic event, a repeat episode of atrial fibrillation. But in fact, We know from many studies in patients, for example, who had implanted devices, that there was no atrial fibrillation identified in many of these patients that have had stroke subsequently. And in fact, the atrial fibrillation is only a risk identifier, a marker of some underlying atriopathy that may separately predispose to stroke. By the same token here, bradycardia may be a risk marker for some other issue. And to that extent, we may expand the guidelines to the importance of identifying bradycardia by whatever means, and then suggesting further evaluation in terms of what the implications may be. Now, I think that it is premature at this point to know what to recommend in these patients. And so where we go from here was extremely challenging, but clearly bradycardia is not a good finding in this study. But the separate implication, aside from are we inclined to overtreat these patients with pacemakers, is what do we do with these findings, and should we be screening more for bradycardia?
Well, thank you. I think that's a really important overriding conceptual model for this. And I think the study was so wonderful in both the surprising findings with respect to how we can overdiagnose and potentially overtreat a lot of these diseases that are becoming increasingly easy to identify. I want to thank both of you for joining me for this podcast. I'm Kristen Patton, and I've been speaking with Dr. Søren Diederichsen and Mark Schoenfeld about the prognostic implications of incidentally diagnosed bradycardia. You can find a link to the paper in the episode's description. Thank you for listening to this JAMA Cardiology podcast. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by Daniel Morrow at the JAMA Network. The audio team also includes Mary Lynn Ferkalak, Audrey Foreman, Lisa Harden, Hannah Park, Shelley Steffens, and Dr. Linda Brubaker, Senior Editor Multimedia. Thanks for listening.